Hello, everyone. I'm very happy to be here with distinguished guests. We have Professor Carlos Mateo, and we also have Professor Giampaolo Gini, who's going to be talking to us about very interesting stuff in retina and the overall exciting surgical retina part. But before we start, it's a good opportunity to really hear from you about your experience with EPOMEC. I would like to hear from you, Professor Carlos, first. How did you find it?
Really, this is an exciting meeting in the world now. This is because, you have this room, plenty of people, at the same time talking about different things, and you have the opportunity to share different ideas. It's a great meeting, it's a great idea, and, it's amazing the quality of people you have here. This is an honor to be here, and really thank you for your kind invitation.
This is we are very honored to have you, actually. Professor Gini, you've seen the format in which you have those three screens showing three different presentations at the same time. How did you find this so far?
Well, let me just start by saying that this part of the world, the Middle East in general, is expanding, growing very fast. I was here 30 years ago, my first time, and it's unrecognizable. There's a commercial on television where someone drives the car in the desert and you see springing skyscrapers all around. And this is exactly what has happened here. And this is a booming ophthalmological society as well. So you have all these people that are getting into complex vitreoretinal procedures. So it's wonderful to be able to share this experience with them. And I see that EPOMEC, which is now in its 12th year, is really taking on the role of leader in this field. And the three screens are just one more thing which adds greatness to this meeting. It's really exceptional, outstanding.
Thank you. This is very exciting times in general in the region. So let's move on to the area of surgical retina. I know you two love doing surgery. It's something, those who do this really enjoy the time that they enter the OR. So I just want to ask you, this is something that's been trending now, and especially in this part of the world, there's not a lot of adoption to it yet. Vitrectomies for floaters.
Floaters?
Yes. What do you think of it? What's the experience? I would like to hear from both of you, actually.
In the past, 3 years ago, I was thinking that, floaters, live with it. But now, we're more people with, premium lenses, more people say the fact, younger, and they're complaining more and more about floaters. Then, it's a nice surgery. We have machines that, are very safe and very efficient to remove these floaters. Then, we planned and we study the patient. We, tell the patient the risk they have, but, we are absolutely open to remove them if the patient is really complaining about this.
So what? I assume you also have a similar experience. What would be something that you would look into in a patient?
I think I'll have a talk on this tomorrow, but essentially, floaters are a misunderstood phenomenon. And as I will say in my talk, we did with a researcher from Chichester University, we did some research to try and understand and answer some questions regarding floaters. To begin with, we understood that what the patient reports is not what the ophthalmologist sees, because the symptoms can be 1,000 to 1 million times greater, the shadow on the retina, than what we see, because the forward scattering is much more than the back scattering. So one thing, we don't see what the patient says. So we have to rely largely on patient symptoms. And that obviously opens up a whole new chapter in vitreoretinal surgery, because we're used to doing things when we see them. Now we have to rely on the patient telling us. So if we let some time pass for neuroadaptation of the patient to the floaters, and the symptoms persist and they affect the patient's emotional, social, professional life, then that is a good reason to intervene. And we have seen with the EVRS study on floaters that actually the percentage of as Carlos was saying, the percentage of complications is very low. This is because we have new machines, we have safer methods, we have better surgeons. So it is something which can be done. Obviously, always with the patient consent, very informed on what the risks are, and then if the patient agrees, we can proceed.
Let me add one thing about
Absolutely.
floaters, because he mentioned one thing that we don't understand floaters, and this is true. The comparison is in high myopes. High myopes have a huge number of opacities in the vitreous. Many of them, you ask them, you don't see floaters. Oh, well, I don't care. But in an emmetropic eye, pseudophakic patient, small floaters you see, and the patient says, I can't live like this. Then we have to understand better what is the meaning
Yes.
of floaters for them.
So there's with the electromagnetic mathematical model which we developed for this, we understood or partially understood why. So apart from all the psychological neuroadaptation and so forth, it's also a physical concept. So in the very high myopic eye, the floater is not in focus. So it's only the floaters which are closest to the retina and are in focus that give that particular visual disturbance. And that is why now with the multifocal lenses, you get patients complaining more of floaters because the floater is always in focus. And so that is something to be considered when you are implanting multifocal lenses. And that explains why the myope is less affected than the emmetrope in perceiving the presence of floaters.
Yeah, I think generally our patients are becoming more demanding because they really have more demands in their daily life and with the things that they do in their work, and this is why we need to also listen to them, and I think this is very critical. I just have another point that I want to bring up. In the retina world, we deal a lot of different tamponades, things that we put inside the eye to help the retina go to its normal position, and we hope that they work. But we know that generally this is something that can be troubling for the patient. Sometimes the patient with a gas bubble inside the eye might not be able to travel, or the silicone will need another surgery, and this is something that can really make their life a little bit difficult in the post-operative period. So any exciting stuff that we can listen to hear from about this area that you can share?
There is a lot of research about new hydrogels or MCPs to use in vitreoretinal surgery. There's a lot of research, but we don't have it yet. We are trying to find the ideal tamponade, and then we are trying to find a new concept for what's an ideal tamponade. But let me tell you, there is one added problem to this. These gases we use in, perfluorocarbon liquids and C2F6 or SF6 or, not air, of course, but all of these elements produce greenhouse problems.
Yes,
But this is very powerful, had a power to induce, the global warming problem. Then, we have to continue to try to find any, ideal tamponade that today is not available.
Absolutely. I think this is also a very, very big, important point that people are very concerned with, and definitely, keeping the environment in mind is very important.
So,
yes.
The ideal tamponade doesn't exist yet, but we are working on it. I'm confident eventually we will get there. Right now, we have to do what is best for the patient. Now, the greenhouse effects are greater with SF6 than C2F6. So if you are concerned about the environment, I would recommend you use C2F6 instead of SF6. And that will give you peace of mind that you're saving the environment.
Absolutely. There's a lot of things that we can do in that area, specifically with regard to consumables that we use inside the OR. But I know you guys are busy. You have talks to catch up to.
Yes.
And I really appreciate your insights and the effort you put into this work that you're going to present in this meeting. And we're very, very happy to have you here with us.
And can we just thank you for this
Thank you very much.
very welcome invitation. Thank
You're
you and
welcome.
well
Thank
done.
you.
Very
Thank
happy
you.
to see you.